topic today. Tashna, can you put it into the presentation mode? My kind of presentation is on the optimizing the nutrition in wound care. So this is something very much important when you are dealing with the wound healing process. Can you put the next slide, please? And these are the things that I'm going to cover today, and what are the aims of optimal nutrition, and how are we going to early identify the poor nutrition, and what are the essential nutrients for the wound healing, and what is the optimum diet, and if there are supplements, what are the rationale, and then how do we adjust for the diet for the comorbidities, because most of these wound patients, they have so many comorbidities. Next slide. So when we first look at the aims of optimum nutrition, so why do we consider about nutrition? The one of the thing is we had to really look at whether these patients are really malnourished or nutritionally okay, or whether obese or whatever. The obesity and the undernutrition, both we consider as malnutrition. So first we had to correct the malnutrition and especially the undernutrition, and then we have to restore their nutrient intake. So this is something very much important. Whenever you see the patient, you have to really look at that component. And the next one is there are many nutrition deficiencies, especially the vitamin and mineral and the micronutrient deficiencies. So one of the thing is we have to treat it, or other thing is we have to prevent the development of the deficiencies. These are the two things we have to do. Then the third part come with the wound, that is we have to look at the healing of the ulcer and to prevent the further breakdown. Then fourth one is in the nutrition, it will help to improve the infections and the improving the immunity, as well as it will kind of to assist to a certain extent to the comorbidities also. Then in the optimum nutrition, so we are not really going to use the kind of count in calories, but we have to really look at how much they are roughly taking, estimating, and whether they are really taking appropriately, or whether it is a sufficient diet or insufficient diet they are taking. And another component in the optimal nutrition is skin integrity. So once the wound is healed, we have to the patients have to maintain the skin integrity. That's another component which is important with nutrition. And as I mentioned you earlier, the other one is immune system supporting and the reduction of the inflammation. So all these 8 factors are very important when we look at the optimum nutrition. That's the reason in each of these wound healing process, we had to look at in the whole during the whole process, we had to look at the nutritional component. If you have any questions, you can raise your hand, then we can always discuss, or otherwise at the end, you can ask questions. Next slide, please. Then the next component comes when the patient come to you. How are you early identify the poor nutrition? So the one of the easy thing is, because you have the very small minimum number of time. So during that time, how do you assess it? One thing is you can ask from the patient whether the patient has any unintentional weight loss, because some people, they have the weight loss due to, they intentionally lose the weight to reduce their weight. But if these patients, they come and tell you, I didn't attempt to lose the weight, but I am having the weight loss. That's a very big component we have to think about. Other thing is a poor appetite. And the other thing is a decreased food intake, because some might not tell you the appetite, but they say, I am taking the less food compared to those previously. So that these are the 3 things we have to look at, and it is one of the alert areas of the giving the poor nutrition. That's the things that in the history we ask. Then the next one is examination part. You can look for BMI, and you know what is BMI, how to calculate, and you don't need to calculate. There are many apps are there. And with the weight and height, if the BMI is less than 18.5, that is something we have to really consider as an underweight component. And some patients, we can't really look at, measure the height, and they also don't know their height, and when we ask, and sometimes they don't know even their weight, because sometimes the bedridden people, we can't really measure their weight. So in that sense, you can always look at the mid-upper arm circumference, that is from the shoulder to the elbow, that point as shown in this picture. You can see, get the midpoint, and just a normal tape can do this work without much problem. And if it is less than 22 centimeter, we consider them as similar to BMI less than 18.5 and the underweight people. And another obvious thing in the examination that we can look for is muscle wasting, because especially deltoid and then all the leg muscles, and those are the muscles get wasted. So that also obviously tell us first patient is having the kind of going under the malnutrition component. So this is a way we can early identify the poor nutrition component rather than waiting till it get aggravated. Next slide. What are the essential nutrients for wound healing? As same as something for all of us, we need calories. That means we need energy. We need protein. That is the most important part in wound. And then the water, that's hydration. This is very much important. And the next one is vitamins and minerals. So these are the 4 components really needed when we are really looking at the wound healing process. Next one. So I'm really looking at all these prevailing guidelines at this things, but at the end of that, I will give you some case scenarios. Then we can see how these guidelines will be applied for, how can be applied it for the patients. Now, when we look at the protein requirement, usually this is something have to be very critical with the wound healing. Because in the wound healing process, and the protein really provides a lot of, they give the lot of functions, collagen development, preserving the muscles and the tissue maintenance, as well as the wound exudates, which contain proteins. So therefore, we know with that, the protein loss will be lost, and then it will impact the healing rate as well as the metabolic demand. So in that sense, in someone is needed for the calorie, about 50 to 20% of calories should come from the protein. But you don't need too much worry about then how do you calculate it? If you know the body weight of the person, you can see 1.2 to 1.5 gram of protein needed for a person in that sense, because they have a positive nitrogen balance at the moment. But if they have the severe wound and the great losses, if you say with the exudate, then you have to really increase something like burn patients. So you have to increase it to the more than that. It is 1.5 to 2 gram per kg per kilogram of body weight per day. But usually we don't go beyond more than 2 grams. But some instances, you can even, some wounds, you can go even beyond 2 gram per kilogram body weight. But you have to be very cautious whenever you are going beyond that, because sometimes it has a negative impact with the renal and hepatic functions. Because if the patient is having the another comorbidities, you have to be a little careful whenever you are handling that part. Next slide, please. So you don't need too much worry about calculation. This is an easy table for you. If the person's body weight, you can really look at them for the healthy adults, how much of protein servings people need. Serving is in the sense what we put it into our plate from the pot. So that is what in the one serving we usually say one serving is something like 7 gram of protein. So you can see that according to the body weight, how much of protein a normal person needs. And the third column is the amount of protein that people need for wound healing. And the fourth column is some people, if they have the chronic and the severe wound, how much of protein servings they need. So for that, these things you have to multiply with the 7. So then only you can get the gram of protein that they need per day. Because 1 is equal to 7 grams. And then you can see how much of protein some need, and sometimes even this 45 kilogram body weight, if they have the severe chronic wound, so they need something about 70 gram of protein per day. So the next problem comes is, how are we going to give this protein? So what are the alternatives, and what are the food types, and what type of food people have to use? Next slide, please. So this is a list of foods. This is just for you to really look at. And then because there are many food groups and the food items which has proteins. And then there are cereals, pulses, and the things in the cereals also, like rice is our staple diet. And you can see even the 2 cups of rice. If we have 2 cups of rice, and you get about something like 1 protein, only 7 gram protein. So this chart is there. You can always use it. And even the bread also, if you have to have the 4 slices to get the 7 grams of protein. And this dal and chickpea and all pulses having a little bit of more protein. They have the carbohydrate plus protein, but the protein, they can have it even the half a cup, you can get the same amount. So why I'm telling this thing is to show you how much of food people have to eat to get this type of protein. Next slide. When we look at the meat, and there you can see even the small piece of 30 gram of meat and fish, you can get the same amount of protein, and even the egg also. But another thing is people use only egg white rather than egg yolk. You can see to get egg, if we are now removing egg white or removing egg yolk and using only egg white, how much protein we are losing. So that's another part we have to think about, not to remove these egg yolk and have the whole egg for people. Because whole egg, especially egg yolk, is having a lot of other nutrient factors for food healing purposes. The nuts and the other things, you can see that, I'm not going to tell you the one by one. So these are the things you can always use this table for your kind of reference. Next one. The next one comes now when we are talking about the protein, then we know our building block of protein is amino acid. There are 2 types of amino acid. One is essential amino acid. Essential amino acid we can't produce in our body. That's what it becomes essential amino acid. So we have to take it from the food. And the other thing is there are some other things are non-essential amino acid, and there's another component called the conditionally essential, because we can produce it in the body, but still in the wound healing it is very much important. So in that sense, in the wound healing purposes, the leucine is something very much important as an essential amino acid, because this really help to form the new tissues, as well as it reduces the muscle protein breakdown and increase the protein production. This is why leucine is very important. But when we look at the other conditional essential amino acid, because this we can really produce inside our body, but still it's better to give sometimes in the wound healing process from outside. So one thing is arginine, which will help to repair the tissues even in the acute wounds as well as the chronic wounds. Next one is glutamine. Glutamine also helps to DNA production and cell growth. So these are the 3 main essential kind of amino acids which we really consider during the wound healing process. Next one. Then the energy requirements. When we look at energy, the metabolic demand is very high, and because due to injury and because of the wound, and especially depending on their overall nutritional status, they may be malnourished. So under that, and they may have all these things considering, we always look at with the underweight or losing weight patients, they need about 35 to 40 kilocalories per body weight per day. But if they have the pressure ulcer, 30 to 35 kilocalories. But if they have a chronic ulcer, they need the much more energy, that is 50 to 60 kilocalories. This is what it changed depending on the patient's requirement. So anyhow, we really need the energy requirement has to be met. Otherwise, what happens is the muscles will be break down to get this energy, but what is required for the person. Then what happens is the other muscle, they will lose the muscles and they get more wasted. Next slide. The next important component is a fluid requirement. Under the fluid requirement, especially this hydration, those patients should be well hydrated because it really have an impact with the healing process and the skin turbo. And the other thing is it will contribute for the good perfusion and the oxygenation. So the usual recommendation is 30 to 40 ml per kg fluid people have to take. And sometimes if they have a fever, diarrhea and things there, and a lot of exudates from the wounds, they have to have the more fluid than this recommendation. But at the same time, here we get the usual fluids, we get 20% from food, but other things, other 80%, we have to take it from the kind of beverages, whatever, water or any other beverage. Next slide. The next other things are the vitamins and minerals, especially we have to look at this anti-inflammatory vitamins. One is vitamin A. Vitamin A is really important in the protein synthesis as well as the immune system stimulating, epithelialization and the wound strength, collagen formation, and all these things, it is very important, the vitamin A. So usual recommendation is, especially for the people with the corticosteroid and thing, to short term, like 2 weeks supply of 10,000 to 25,000 international units per day is recommended. But very high doses can lead to the toxicity as well as chronic renal failure and all sort of things. So you have to really consider what type of patients that you are prescribing these things. So it is very important. But other thing is when we look at the food, you know that there are a lot of food which has vitamin A. Without even taking supplementation, you can even take from the food without much problem. There are a lot of things I think I have just listed out, and you know most of the things. But for your kind of knowledge purposes, I have just listed some of these high rich vitamin A food high rich with the vitamin A. Next one. The next anti-inflammatory vitamin is vitamin C. Vitamin C is actually all of us know that it is really kind of essential cofactor for the collagen synthesis, as well as it enhances the leukocytes and macrophages and the formation of the new blood vessels and the wound strengthening, antioxidative capacity and increased iron absorption. So many functions are involved with the vitamin C. So vitamin C, one of the major vitamins that always we consider during the wound healing process. Usually if the kind of we don't much, if there is deficiencies are identified, you have to give the 62 to 100. Otherwise, in the stage 1 and 2 cancer wounds, recommendation is 100 to 200 milligram. But if it is a stage 3 and 4, and those wounds or seriously injured and the malnourished patient usually go for the 1,000 to 2,000 milligram per day. So this is a kind of recommendation. And then we have to considerations are the people who are with the renal failure without dialysis and the risk of renal oxalate stone formation. So those are the other things you have to really consider whenever you are prescribing high doses. And the sources of food, there are, I have just listed the very very high rich sources that people don't much use it, like drumstick leaf, green mangoes, radish leaves, spinach, and all these things, our sup and things, because everybody know that nelly, guava and things. So I thought that I will give some of the few examples which are not really used by people much. But those are widely available without any problem. Anyone who has no money even can buy all these things. Next one. Then the other vitamin mineral is zinc. Zinc also helps to synthesize the collagen and protein. At the same time, especially the wound strength and the cell replications, and it assists the immune functions and the metabolism. So this is something very much important minerals. And usually we don't much diagnose the deficiencies because Sri Lanka we can't really do any testing, but other countries they do the mineral panels and they diagnose and then they provide the supplementation if it is needed. But in our case, because we can't do the zinc level, but the usually recommended dose is 15 milligram per day. But if we consider if they have a deficiencies, you have to give the higher dose like 25 to 40 milligram per day. Usually the recommendation is only for 10 days. But at the same time, you have to really look at whenever we are giving too much of zinc, what will happen is you can get the excess zinc will cause a copper deficiency, which will delay the wound healing. That's another component you have to think about. And then the other thing is sometimes you get GI discomfort and the toxicity levels are, I mean, if we are going to very high doses, can get the toxicity, but usually we don't really go for that type of high levels, high supplementations. But the sources of food, I thought I will just give you the kind of your unfamiliar food, like this kurakang, olu seeds, and the rulang and kallu, these all the traditional rice and then cowpea, green gram, dal, all these things are having zinc. So people can take zinc without any problem from the food. Next one. This other one is glutamine. So I addressed this one earlier. It is as a conditionally essential amino acid. But glutamine is important in sometimes in the wound healing, especially with after the major surgery, trauma and the brain injury and things to enhance the immune functions, and it will improve the nitrogen balances. At the same time, it will act as an energy source for the inflammatory cells during healing. But recommendation is providing the 0.57 gram of kg per dose. That's a maximum dose. But there are kind of these research are very inconsistent. Some there are positive research as well as negative research. So therefore, these sometimes this won't really practice some cases. But still, there are so many foods are there. If you really need to prescribe for patients or tell the patients, something like barley, rulang, dal, spread streams, and all these things, chicken, beef, and egg all contain the glutamine. So if people are taking all these things, they don't need to much worry about it. And the other amino acid I mentioned was leucine. This is the essential amino acid. It is very much needed, but that's also contained in many food like maize and this chicken, shark, and beef and egg. So if someone is taking egg every day, this wound healing process, I think one egg is not enough. At least they can go for 4 eggs. And then the most of these amino acids and the most of the vitamins and minerals can be really, they can get it from from eggs. Next one. Then the arginine also, that's another conditionally essential amino acid that I mentioned there. And that's also important in the acute stress and it promotes the protein synthesis and immune functions, as well as it improves the wound strength. But there are not much evidences and guidelines, but still that grade 2 wounds, they recommend about 17 to 24.8 gram of the free arginine. But still that sometimes there are some toxic adverse effect and everything. But when we come to the food source, or that all seeds and the baby shrimps like Pulisa, they have this arginine. Next one. So what are the comorbidities that we have to consider during this wound healing process? One thing is the main one is the diabetes. I think this is something very much important to look at, because these patients, the consistent protein and the consistent carbohydrate intake is very helpful to control the blood sugar. Because of the hyperglycemia, it might really affect the wound healing process. So it's very important to provide the consistent protein and the carbohydrate kind of diet. Then another comorbidity is age in adults, and sometimes they might not able to take the calories and the whatever energies and the protein that we mentioned. So then they have to take some oral supplements, or sometimes they have to go for the specialized amino acid mixtures, something like arginine and these all glutamine containing things are there, which will enhance the collagen production to heal the wounds. And the other thing is, especially micronutrients, these are very much needed for the wound repair, not only the one I mentioned, but there are so many things like copper and all minor minerals also, they might need it because they might get the subclinical deficiencies, and they really need sometimes all these minerals also to support the healing process. So they usually, in that sense, they might need some specialized oral nutrition supplements for their kind of effective wound healing. Next slide. So when we really look at nutrition management, now this is a kind of in summary what I have been really discussing you all this time. And the one thing is there are two parts. Wound is there, ulcers are there. So in the wounds, the energy needs is usually moderate, but the ulcers, it is very high. But when we look at the protein needs also, wounds, it is kind of 1 to 1.2 grams, but the ulcers in the sense it's a chronic process, it will go to the 1.2 to 1.5 and even up to 2 grams per body weight. And the micronutrient demand in the wounds, it is moderate, but ulcers, it is high. But the duration of the nutrition therapy, wounds, we can have the very short duration nutrition therapy, but ulcers, we have to go for the prolonged nutrition therapy. Next slide. So the next one is, how are we going to feed these patients? What are the feeding route priorities? How do we select which feeding route is important for these patients? Now, the first choice is oral nutrition. So in oral nutrition, the indication is patients usually they are able to eat as well as they are able to swallow safely. So we can really use the oral nutrition, but however, it is a first choice. And if they can meet about 60 to now, I told you how to calculate the energy. If they can really meet about 60 to 75% of their protein and energy needs, that's fine. You don't need to much worry about it. So the strategies, we have to really everybody eat the 3 meals per day. So these people might have the loss of appetite and the poor intake and things. So they might take the very less quantities, but still people need the 3 meals. And in addition to that, these people need the small snacks also in between, maybe 2 or 3. So especially in the all these meals, we have to really consider the high protein and high energy diet as well as this, and sometimes we can really take if we feel it is inadequate, they can as a snacks we can give the oral nutrition supplements. And why that oral nutrition is much important, because it really preserves the gut integrity. This is very much important, as well as it will give the few complications. How are we going to monitor? So when the patient comes to you, you have to get the weight of the patient and see whether the patient is improving or weight gaining or static or whether reducing the weight. So this is a very important component to look at whenever you see the patient. And the intake, you have to always ask from the patient, are you taking, are you reducing the things? That's another important thing. At the same time, wound progress weekly. So this is what we have to look at. How this first choice is enough, or whether we have to go for the second choice. What is second choice? Second choice is the enteral nutrition. So when the oral intake, if you think it is insufficient, or then we have to really go for the long-term one. Short-term one is NG tube, and the long-term one is the PEG. So these are the two things, like stroke patients and with the pressure ulcers and things. So you have to really think about these things. But still, sometimes you have to really look at in the palliative concept also. If the patient can really have the oral one in the safer manner, better not to go for the inchy tubes and thing, because sometimes if the inchy tubes, a patient do not have a way of communicating after that. So that's another agony for the patient. So then the formulas are there, something like high protein formulas are there, energy dense formulas are there, as well as immunonutrients like arginine, glutamine, omega-3. So there are different kind of formulas are there. I think many drug reps must be coming to you and they showing that this and that and things. So just concentrate whenever they are coming and telling you what are their components, what are their supplements, and whether how can you use those things in the effective manner. So the still the enteral nutrition is growing through the gut. I mean, we can preserve gut functions, but it is better than the parenteral. But at the same time, everything, whatever we do, we have to monitor. One thing is we have to look at the daily intake and then the tolerance. And the other thing is, important thing is the electrolytes. And you have to really look at the electrolytes, and the sodium and potassium are very much important to look at whenever we provide this enteral nutrition to the patients, and the wound healing process also as a monitoring process. Next slide, please. So the third last choice is parenteral nutrition. So when the gut is not functioning and enteral feeding is not tolerated, then there's no other choice. You have to go to the central or peripheral IV line and go for the parenteral nutrition. Usually parenteral nutritions are available in the different forms. There are amino acids are there, dextrose is there, lipids are there, electrolytes, vitamins, trace elements, or sometimes all these things are together in the one mixture. So different way of being, whatever things available, whatever the thing feasible, you have to select it. So there are many precautions you have to take whenever you are using the parenteral nutrition, like risk of infection, metabolic complications, liver dysfunctions. You have to do many testing, electrolytes and all these things you have to really monitor, daily labs testing, liver functions, and then these are the kind of problems with the parenteral nutrition. You have to really have the good daily labs testing for most of the time. And then you have to monitor the wound healing. So whatever things I have to tell you, use oral nutrition whenever difference between parenteral nutrition and enteral nutrition is enteral. That means you are putting it to the gut. So how are you going to put it in the gut? One is through the NG tube or through the PEG. But parenteral is you are giving in IV. So that's one the difference. You are putting it to the gut, or other thing is you are giving as in the IV line. These are the two different things. And then oral nutrition is the first choice, and then if it is not adequate, only you have to go for the enteral, and the last choice is parenteral. So I think most of our patients with the oral nutrition we can maintain rather than even going to enteral one. Next one. So this is just an example for you for the suggested diet for the patient who is 60 kilogram. What to give, and this one, just look at the amount of food that they need. I have really given you how to justify and how to calculate and how to look at their requirements. And then the breakfast, you can see how much of, the things like eggs and the rice and something like these things are important. Even the mid-morning snack, also some of the protein product as well as vitamin A rich one, and then lunch again, something like protein plus energy. And then the mid-afternoon, the best one is nuts, peanuts, and sesame and things are very good. And because it does not fill up the tummy, then they can have the dinner without much problem. And the dinner, and at the same time, even before bed, they can have something like for the hydration, maybe tea and black tea and things, or even the kanchi and the milk they can go. But if there is a pressure also something, these are something like prescription you have to really look at. 1000 milligram of vitamin C, 30 milligram of zinc, arginine. You can ask them to have the pumpkin seeds and peanuts. And the 70% protein should come from animal protein, and another 30% we can get from the vegetable protein. At the same time, this leucine, to get the leucine, they need the beef, pork, chicken or egg, whatever things include in daily diet. So these are the kind of roughly the people should really have their food during the kind of for the wound healing process. Next slide. So I think I have a few minutes, and I will just quickly go to the 3 cases that I have prepared for you. First case is a diabetic foot ulcer. This is a chronic non-healing wound that you can see from the picture. This patient is a 62-year-old male, type 2 diabetes for the 15 years, and the HbA1c is 9.2%. So the wound, it is a plant foot ulcer, Wagner grade 2, that is, it's a deep ulcer. It is reaching to the tendon, bone, and the joint capsule, but no abscess or osteomyelitis, present for 8 weeks. So what are the findings? And with the patient, and the BMI is 21, and the patient has a recent 6 kilogram weight loss, albumin 3 grams, and the poor appetite. So what is the nutrition strategy would you implement to accelerate the healing and prevent infection? So anyone can really tell me within 1 minute? Then otherwise I will discuss it looking at the permitting the time, because I think I have lost 15 minutes. Sorry for my delay. But if anyone can really interact.
Hello, ma'am.
Yes.
So I think, firstly, in this case, we know that he's having a comorbidity.
Yeah.
The patient is having a comorbidity, and it seems to be a poorly controlled one because HbA1c is at 9.2%. And with that, when we've come to the wound, because we have an unhealing ulcer, then when we, in the history, we know that there is a weight loss in this patient of 6 kilos.
Yeah.
And poor appetite also is mentioned. So there is some nutritional deficiency ongoing. And then when we come to the BMI is within the normal, but towards the lower aspects as 21. So I think in terms of essential nutrients here for this patient, the first thing we would look at is the proteins, focus more on the proteins, and also the control of the comorbidity. So this patient will need to be admitted to get the sugar levels under control.
Okay. Right. And Shashna, can you put the next slide, please? I think next slide. I think you have to pin, not me, the slide. I can't see that slide.
Can you see now?
No, I think you have pinned me. I think you should pin the slides presentation.
Okay.
No, I still can't see. Okay.
I think she's asking for the previous slide.
No, I'm asking the next slide. The one we discussed now. Yellow color with the ulcer.
With the ulcer.
Okay,
Yeah.
Aisha.
Now we can't see anything.
Yeah, we can't see anything. Okay. Right. Yeah, just go down. Yeah. Yeah, this is it. So after another next slide, I want. Yeah, right. Okay. So these are this in the discussion point. Now patient is obviously having, not this one, Sessioon. Patient is obviously having malnutrition because patient has lost the, though patient's BMI is normal, patient has lost the weight. So I told you that's one of the indication that we consider it as a malnutrition. So as a result, this patient is malnourished, so need the very high energy than the normal patient. So usually we recommend about 50 to 60 kilocal per body weight. And in addition to that, this wound and this chronic wound, we need to give the more protein, something like 1.5 to 2 grams per kg. And in addition to that, because patient is malnourished, we know when they get the more vitamin and mineral deficiencies, most of the thing we can't test it. So as a result, we usually give the some multiple vitamin and the mineral one. Most of the vitamins and minerals have 15 vitamins and minerals. So that's the one that whatever the formula, you have to select it. And to recover from the malnutrition, they need this normal vitamin and mineral supplement. Then the next one is, as you mentioned, it is very good and the glycemic control, because hyperglycemia will affect the wound healing. So we have to really look at the low GI food for these patients, because with the high GI food, it will get further aggravated. And another thing is the foods with the soluble fiber is very important, and then having the consistent carbohydrates throughout the day for their things. If they have another thing is monitoring the blood sugar is very important, maybe 2 hours after diet, or now currently you have the continuous glucose monitoring system. They can have that even if they have money. And in addition to that, they need the arginine, about 20 grams per day, maybe for the 2 to 4 weeks. And then the next one is a zinc, because we are in the multiple in the vitamin mineral formula always have the zinc something, so you can add another 15 milligram per day in addition to that for the 2 to 4 weeks. Vitamin C, they need about 1000 milligram per day for 2 to 4 weeks, and the vitamin A is coming from the multiple vitamin mineral formula, so you don't need to give vitamin A separately. So this is a kind of management you had to really look at for that patient. Next slide, please. So the second case is a pressure ulcer in a bed-bound elderly patient. So this is a 78-year-old female, post-stroke, bed-bound, grade 3 sacral pressure wound, and the BMI is 18, and and anemic, HB is 9.5, and having vitamin D deficiency. So what is the kind of nutrition care plan that you are looking for healing and prevention of recurrences? So someone tell me very in the nutshell, how do you manage this patient? Can someone just voice up?
Shall I go again, ma'am?
Yeah, yes, definitely.
So I guess this patient, again, from the history, we know that this patient is having a poor lifestyle. So she's having a stroke, already post-stroke. So, and being bedbound. BMI is at 18, which is quite low. So there is a definite nutritional deficiency and already lacking in oral intake and anemic and vitamin D deficiency. So there's a low iron as well, which is going to affect the wound healing. So in this patient, we need to go again with a high energy diet, but the route we'll be taking would be most likely parenteral nutrition because the patient is having a poor intake.
Okay, thank you for your responses. And can you just, Sachna, move to the next slide? So this is a management. Now, this patient is definitely malnourished because poor intake and the BMI is 18. So we have to really go for the energy about 40 kilocal per kg per day. And then they give in the vitamin and mineral supplement, normal vitamin and mineral formula, tablet or capsule for till malnutrition is resolved. Then for the pressure ulcer, what we should give? Protein, you have to you don't need to then go for the very high protein, but at least they need 1.5 gram per kg per day. Vitamin C, you can give the 100 milligram per day is enough, and the patient need iron, vitamin B12, folate, all three containing supplement. for anemia, because we don't know what is the reason, whether it is iron or vitamin B12 or folate deficiency. So better to go for because 78 years person, better to go for the iron, B12, folate, all three contained in formula. Especially looking at the iron in the 60 milligram per day. Sometimes if it is not responding, better to go for the 30 milligram. 30 milligram is also sufficient sometimes for the anemic patients because it absorbs very well. And the giving with the vitamin C 100 milligram. And the vitamin D, better to give the 60,000 international unit weekly for 6 weeks for the vitamin D deficiency, because then the number of tablets are less for the patient. And then for the poor intake, you don't need to go for the parenteral. You have to use the oral supplement, oral nutrition supplement, which contain about the 1 kilocalorie per ml, and each contain about the 10 gram protein. So if you can give as a three or four supplement for this patient per day, this patient does not need any enteral or parenteral. Patient can have the oral supplement, oral intake, and can resolve the problem, because still patient is only BMI 18, not that malnourished, not the severe form of malnutrition. Next case. So the case 3 is the surgical wound dehiscence after the abdominal surgery. This is another common one we always look at. This is a 54-year-old female post-hysterectomy, partial wound dehiscence on the day 7. Findings are the patient is obese, recently crash dieting, and the low protein intake. So how should we optimize the perioperative nutrition and to prevent the complications? Open for someone to discuss. Can someone come up? Because I want to finish actually quickly. Now the next lecture is waiting. Sorry for that. So, shall I go the discussion? Can you just put the slide, next slide? So this patient, it has a protein deficiency. You don't need to go to too much of protein. That patient need about 1 to 1.2 kilocal per kg per day. Energy you need about for a normal person like 0.8 kilocal. And the mainly perioperative nutrition optimization in this patients are arginine is important, vitamin C is important, and zinc is important. So these are the 3 things this patient really needs. Now you can see all these 3 cases, how it really changed the management. And some patients really need some of the form vitamins and minerals. Some patients do not need it. So this is very important to look for the things and examine. And what are the problems the patient is having? According to the problem only, you have to do the management. Next one. Next slide. So this is something like a clinical algorithm I just prepared for you to for your easy things. So when the patient with wound it come, you have to really look at the nutrition.
Madam, sorry to intervene. We can have another 10 minutes because the sun is quite busy. But yeah, we can go on, madam. It's okay. Take your time.
Sorry. Okay, I will go slowly then. So then this is a clinical algorithm. What I have mentioned all this time, the last, I think almost 45 minutes, this is in nutshell. You can see when the patient present with wound, first thing is you have to look at the nutritional risk screening. Looking at the MUAC, BMI, whether the patient is elderly, chronic disease, large or deep wound, burns or major trauma. This is your assessment. Then the next one is going for the comprehensive nutrition assessment, something like we are looking for the weight loss, dietary intake, functional status, and then the looking at the hemoglobin, CRP, albumin. These are the basic tests you have to really look for. Then you classify the wound and the metabolic stress. If it is a surgical minor trauma, we consider it is a kind of very moderate metabolic stress. But the pressure injury, diabetic ulcers, it has high. But burns and major traumas, it's a very high metabolic stress. Then you calculate the nutrition requirement, looking at the energy, protein, and the burns, it is little bit higher, but I can cover the burns with food. What are the available mineral and vitamin formulas? There are so many vitamins and more formulas available. Just when the drug reps comes, just look at the what are the vitamins and things, so many things, and the well man, well woman, and the so many things, well baby, and the well teen, so many things are there, names. Then optimize the micronutrients. That's the second part you have to do. You have to look for the vitamin C. We can't do the testing, but you have to really look at, depending on the wound, you have to prescribe the vitamin C. And the vitamin A, if you are giving the multiple vitamin formula, you don't need to give the vitamin A separately. And then zinc, iron, vitamin D, arginine, glutamine, selenium, all these other things. Selenium also, when we are giving the multiple vitamin mineral formula, it has selenium. You don't need to really give it separately. Copper, selenium, both are there. Then the feeding route is very important, whether we are going to give oral or whether we are going for the enteral or parenteral. Parenteral is our last choice. And then correct barriers to healing. You have to really look at what are the barriers, whether there's infection, whether ischemia, or whether it is hyperglycemia, or whether anemia, or whether pressure. So you have to really look for all these things. Then the most important is monitoring and the weekly review. You have to look at the weight and the intake and the wound size, granulations, and CRP. So these are the things you have to look at in the monitoring part. So this is something like the very one-page clinical algorithm for anyone to really keep the things in mind. So in that sense, actually, nutrition is one of the core component of wound treatment, and it's not only not the supportive care; it is a very core component in the wound treatment. Next slide. So in summary, I think all of your doctors, you should really need to manage the nutrition of patients while managing wounds. This is a must. And then you have to stay alert to indicators of malnutrition. That is unintentional weight loss, poor appetite, decreased food intake. So all these things you have to always ask from the patient. That is very important. And the proper nutrition is something very fundamental for the wound healing. Especially, we have to increase the energy and the protein intake. And then the key nutrients are, as I mentioned you, to support the wound healing are the energy, protein, arginine, glutamine, and this zinc and B12, vitamin C, and vitamin A. And we have to be aware about the comorbidities, which will prevent the wound healing. And then you have to think about if they are not responding, to provide the specialized oral nutritional supplement always there, which can improve the bone repair. And then it can meet the increased nutritional needs also. So I think this is my last slide. Anyone who needs to ask questions, I think till next lecturer comes, I can really answer your questions.
Anisha, the Wellman stuff are quite expensive since they are UK products.
Yeah, that is expensive, but there are so many things are there. Something like multiform, and so many vitamins are there actually. So many things about cheaper ones are there.
So, madam, what about the vegetarians?
My mind, and I was just telling you, but there are very cheap vitamin minerals are there. I mean, the formulas are there. Sorry, what did you ask?
Madam, what about the vegetarians, madam?
Yeah, vegetarians, we have to, this is what, if the wound healing process, vegetarians has to be really kind of, should have the well-planned diet. Sometimes we have to give the supplements for those patients because sometimes with the poor intake, they might not really take the adequate intake. So you have to be very careful with the vegetarians one. You can really look at these kurakang, olu, and all the other kind of food items like barley and things. But sometimes vitamin B12 and things might not be able to get in the proper way. So then if it is so, you have to really go for this vitamin mineral supplement for some period, at least till the wound healing process goes on.
Madam, when do we decide if we are going to go for parenteral, or what's the fine line basically where we decide, okay, fine, enteral, and then we switch to parenteral?
Actually, parenteral is the last choice. When the usually parenteral, you don't need to much. I mean, usually this is for the mainly for the ICU patients and critically ill patients. But other patients, most of the people, they can really manage with the enteral nutrition. Now, the benchmark is when with the enteral nutrition, if they are not really achieving more than 60%, 70% of their requirement, then only you have to think about that one. So in the usual scenario, it will happen in the critically ill patients and the mainly ICU patients, but most of the patients who are in the ward, they can manage with the enteral without much problem if the gut is functioning. But sometimes with the short bowel syndrome and the gut is not functioning, then you have to think about the parenteral. Those are the rare cases.
Madam, is there any benefit taking vitamin supplements, even though that patient is taking orally with good nutrition status with food?
Yeah, some of the now like patient is malnourished, we know that patients have the subclinical deficiencies. So sometimes with the high metabolic demand with the food, they might not meet the requirements. So that's the reason we give this vitamin mineral supplements for the short period of time, maybe for 1 month. Give it because if they have usually when the patient is malnourished, always they have a subclinical micronutrient deficiencies. So not to get aggravated as well as to it might really kind of go for the delay the wound healing process. So we go for the only maybe 2 weeks or 1 month. Usually 1 month is more than enough for them, giving that. But then you have to really identify the proper vitamin, because you always read the composition and see whether all the vitamins and minerals are included in the vitamin supplements. So when these drug reps bring the things, you always look at least there should be a 15 vitamins and minerals in a supplement. That is the one which is more useful for the patient.
Madam, you had mentioned taking eggs in chronic nutrition. The sense, madam, with cardiovascular risk factors with the egg, is it there, madam?
Cardiovascular risk factors with what?
With egg, when you're taking 4 eggs per day.
There are so many now clinical studies have conducted, and then it was found even the 2 eggs per day is one recommend for even the normal person. But in Sri Lankan context, we don't have 100 gram of egg in Sri Lanka. Our biggest egg is 60 gram or 70 grams. So in that sense, we can have the 4 eggs, 4 eggs without any problem. But in these patients, they are different. I mean, even the cholesterol which is coming from egg, now the new scientific evidence says it does not get absorbed. Only 15% of the cholesterol absorbed from the diet. Mainly the cholesterol kind of was synthesized inside the body. So this is especially going through the saturated fat, not as a cholesterol. So I think all these theories, all theories have now really shown with the recent evidences, and recently even the Harvard has done the clinical trial, and they have also shown they are now with having the 2 eggs, like 2 eggs in the sense they consider the 2 egg is 200 grams eggs, and per day is really recommending them. There are some things in the chat, no? I just can't go to the chat.
Madam, what are the available ready-to-take oral supplements? Kilocalories. That means, I think, it's about energy supplements.
Yeah, I think when you really look at these 1 kilocal per ml things available in the market are the Ensure, Sustacal, and then these are the things. There are so many other brands also. There are 5-6 brands are there. So all these things are having the 1 kilocal per ml. So those are the things which is recommended as supplements. Now, like Sustagen and the other things, it has only 0.8 kilocal. So these are, we don't really I mean, these things are good supplements for the people who need something like supplement for their normal diet. But for the patients, when they need now this type of wound patients, when they need the supplement, you have to go for the proper supplement. So these proper supplement, you have to always look at how much calories are getting from the one meal when it is prepared. So that's the one which is important. Now, I just with the example and the things, it's not, I'm actually not advocating it. I'm just, because you asked me, I just told. But there are so many other things. I just can't remember all the other names. There are 6-7 products in the market.
There's another one, madam. Madam, shouldn't we limit the number of eggs based on the cardiovascular risk factors? Can we give 4 eggs for all who need high protein levels?
Yeah, I just answered that question. I think there's no recent evidences have shown there's no problem. Any other thing? I just can't really see the chat. Prashna, if you now you can close this presentation, then you can see the chart. Then I can see the chat.
Yeah. Are there any other questions? I mean, most of the wound care lecture programs, the certificate programs, they don't include this aspect of wound care. I mean, this is the one of the most important aspects of wound care. And listening to the best person in the field, this is a golden opportunity that you are missing if you are not asking the questions. So, are there any questions?
Someone is asking nutrition in burn patients. Actually, I didn't cover the burn patient. It is something like very kind of, you have to really, it's another one lecture. That's what actually I didn't include it. Because burn patients, the requirements are very high. It always depends on the severity of the burn. So you have to see the 70%, 50%, 30%, like that. All with depending on that, you have to really calculate all the energy proteins and everything you have to calculate according to the severity of the burn. So this is what actually I didn't include in this 1 hour lecture, this burn. So, but it's a kind of, when we really in a summary, they need the more calories and the more protein, because they are kind of they are losing much big. And the first few days it is high, and then all depending on we have to divide it into the stages. First few days, and then after that, and then the recovery and the healing process, like that, different stages, that management is different. But I mean, but when you really look at overall, you need a lot of energy, lot of protein for them to recover from the burn.
There's another one, madam. Is there any source to find kilocalories and protein content of each food and calculate the diet for individual patients?
I think nowadays, I think if you ask AI, they will give everything to you. But the thing is, there are charts actually. I mean, what we use is we always kind of look at now. It is something like counting. We see that cereal group. How many servings in the one servings? It is something like that. It's a bit of the small calculation. There are some charts there. I mean, if you just Google it, you can get it. These charts, like if you Google it, like the food exchange system, you can get these charts. Just type it food exchange list. Then you can get all these things, with all the charts you will get.
Any other questions?
Is Dr. Tushan is not there yet?
He needs another 5 minutes, madam. If there are any other questions, we can take it. Or we can end this lecture and then go on for anything else to be discussed.
Yeah, did we cover all the things in the chat? Just again, I can't see it.
Yeah. I think so, madam. Yeah. We have gone through the chat.
So if you have any question, I think this is sometimes complicated. I mean, very simply, when you see a patient, just look for the nutrition part also and try to manage it rather than sending patient here and there. Because as a medical, I think as a doctor, you should be able to manage that component. It is not a kind of things you can't do. You can always really, if you look at and the few things, I think you will, sometimes you will get more satisfied also when the patient is recovering very nicely, when the nutrition part is managed properly.
So if there are no questions, I think because of the technical difficulties, we couldn't actually welcome Madam as the lecturer. I mean, there are no need for welcome her actually this course. But anyway, I just want to tell a few things. So the Sri Lankan nutrition field is her build. It's being it was done by her. Because of her, all these MDs and MSCs and all those things are there. So we won't be talking about new nutrition. We won't be talking about wound care nutrition. Now we are going to like subheadings of nutrition. So I mean that's as an academic, as a specialist, that's something that many people cannot do. So we are lucky to listen to her, and we are lucky to have her as our president. I mean, I'm very thankful for her, Madam, you, because you accepted to do this lecture. And I mean, you all should be thankful to her to listen to all these wise words. And we all, as Sri Lankans, should be thankful to her for her services in developing the nutrition field. Thank you very much, madam.
Okay, I think it's a bit of the over exaggeration. Thank you, Sujita.
So Tushan will join.
I think Dr. Tushan is joined.
Yeah, okay. Then, yeah, we have another speaker who's making giant strides in wound care as well as diabetic foot care and wound prevention. Dr. Tushan Gunaratna, a vascular surgeon and a senior lecturer of the Colombo Medical Faculty. Tushan has been, beyond the scale bright student from the beginning, and now he's a vascular surgeon, and he will be an eminent vascular surgeon very soon. And I think without further delay, I would hand over to him for his lecture. He's going to talk about wound bed preparation, which is very important, which is one of the topics in your assignment. You have to apply this knowledge. So get as much as possible from this lecture, the jargon, the science, and the way to approach, all that. And you apply it to that patient and write up in the assignment. And it's not only for the assignment; it's for your practice, for your life. Over to you, Tushan.
Thanks, Sujita. And thank you for the kind invitation to contribute to the certificate program for this year as well. And thank you for kind introduction as well. Right. So I hope my screen and my slides are visible, and you can all hear me. Just get a shout out that it's all clear and you can hear me.
Yes, sir.
Yes, we can hear you.
Yes. Thank you. Right. So let's just do a little bit of work on trying to understand wounded preparation and why it is the crucial part of trying to get the wound healed. I'll take it slow. Most of the scriptures, some important concepts are there somewhere in between all of this. So if at any point there's some lack of clarity, sure, just let me know and I'll be happy to explain more. Right. So basically, what I'm looking at, we must understand that the wound is basically a breach of the epithelium. We often talk about surface epithelium, which is more common for our chronic wounds. But if there's any breach in the skin defense, then that's a wound basically. So these are normal two types of things. It can acute wounds or chronic wounds. We all have had wounds, and all of these wounds often would have healed. Those are acute wounds. You get a little scratch or a trauma, get a little wound or a cut after surgery, they all heal. Sometimes wounds don't heal and they go on for a long time. How long that time could be 4 weeks, 6 weeks, 8 weeks, depending on which guideline you take. But if it is not healing by at least 6 weeks, then they can be called chronic wounds. Now, the whole process of how a wound heals is a little complex, but there's some science behind it. A lot of important things are involved, the cells, the growth factors, the enzymes, to try and make sure this healing process works. But in whatever way, form it heals, if it heals, it will either heal primarily. That means that wound is often like a clean cut laceration or a suture or an incision. That's the initial acute wound that heals. But if it doesn't heal at that, and you let a big scar, a big gap, a big gap, then of course it will be called secondary intention, where there's a lot more scar tissue, lot more fibrous tissue, etc., filling the space. So essentially what's going to happen is there are a few phases here. There are a few phases in which how the wound is going to heal. The first part, the initial part is a hemostasis. That means a little clot is formed to fill this gap. Once that is there, it's going to actually be a temporary barrier so that bugs outside can't get back into the wound. And that's important because the moment that there's blood, it attracts other cells to come. Platelet is the one that causes a platelet fibril plug. And that is important because the active platelets entice and stimulate other cells to join in this whole process. At the end of that, as it goes through hemolysis, you get an inflammatory phase. And that is when you find the neutrophils, the mast cells all getting involved and fighting. This inflammation is important because it does give you a little color, change in the erythema. You might feel pain, you might feel swelling. And then with that, you find out inflammatory features. Now, these are not infection. At the same time, you should not falsely start giving antibiotics for inflammation, nor should you be misdiagnosing infections, inflammation also. So be careful about it. Inflammatory phase is there. Once you pass through the inflammatory phase, then you start to proliferate. And these people, these cells with the growth factors and the various cytokines, they keep on pushing new matrix. This is extracellular matrix into this space and fill in this space, and there's a granulation tissue. And that is the one that later on forms collagen and forms a continuous cells. Now, if a proliferation happens, then therefore it should not be happening in abundance. Even after the wound has gone so many times, you can't still build proliferation. Or if the proliferation is not enough, that means there's some lack of important nutrients causing that. So proliferative phase also is important to figure out something might be going wrong. At the end of the whole thing, there's epithelialization and there's remodeling. So remember, a scar will take some time to become mature. And only once it becomes mature will it have some tensile strength to withstand pressure and friction. So a new scar can always easily break down if you don't look after it carefully. Now, all of these first phases, they don't happen in one single continuous process. They happen, but these phases all overlap. You might find certain parts are inflammation, certain parts in granulation tissue. It's a process that goes through, and it's important to understand. Not every single wound goes in the same phase throughout the period. Sometimes, if the wound is in a chronic stage, that means this has got stuck in certain phases. Why has it not gone beyond that phase? Why is it stuck in a particular phase? So every time you assess in this wound, even at wound bed preparation, idea is to try and figure out what is going on. Right. So essentially, we're trying to heal the wound. To heal the wound, you got to have few important things happen. You want friendly factors put into the wound, all the important things to heal the wound. You want to take away all the bad stuff that are going to prevent the wound from healing. And as it must have been told throughout this certificate course, it's very important you look at the entire person, not just the wound in this patient. Now, wound care is simply not doing a wound dressing. It is not simply, it's much more than that, because the dressing itself cannot heal a wound. None of us can heal the wound. It's essentially the patient that heals the wound. What we are doing is trying to create the right environment for the wound to heal on its own. And if there are things that are preventing it from healing, we must make sure we take away those things. If there are important things that are required that are not there, we must put this into play. So, as we come across the concept of wound bed preparation, this is the whole idea. We must understand the biology of the wound, the biology of wound healing, understand there are phases, understand this is a chronic wound that has stopped at a particular phase. It is not progressing beyond this. So when we are preparing the wound, the idea is to try and recreate that process, get the biology back, get the phases back working again, get the process running again, so the patient can go in that same direction and end up with a healed scar wound. Now, they talk about some important things. If you are looking at the patient and you're trying to prepare the wound, like we talked, first it's very important that you remember as a person with a chronic wound. It's important to identify and treat the primary causes. Now, these primary causes have to be understood and have to be sorted out before you even think about touching the wound. There's no point in dressing, no point in offloading, no point in fighting these things unless you're made sure that the primary things required for wound healing have been sorted out. And essentially, they're the three most important things are the vascular, the infection or the injury, and the pressure imbalance. These have to be sorted out before you do anything else. So how you assess for these things, you find out later on. There's a hands-on session. You can see all these things as well. You got to use all the tools in your resources to try and figure out what is going on. Arterial assessment, very important to do all of these things. Assessing the pulse, checking for the features, looking for Doppler if we have the facilities for it, looking at the patient's wound. Sometimes it's very clear, very obvious. It's dry gangrene. You hardly can miss. Sometimes it's not the case. The wound is here and there, it bleeds and you debride, but still next day it looks still dry again. You feel like the blood supply is okay. You keep on perfusing, keep on debriding. Some wounds aren't easy. Assessing of arterial system is very important. Unless you don't check the arterial system, unless you don't check the pulse, you'll often miss sometimes. And if in doubt, refer to the right people, let them sort things out. It is not required for you to do duplex scans to diagnose critical limb ischemia. It's a clinical diagnosis. And therefore, before you do any wound bed preparation, essentially make sure the vascular supply is okay. Similarly, the venous insufficiency has to be looked at. Of the vascular components is arterial, venous, and lymphatic. So it's really important that these are looked at and assessed before you can sort something out. Now, once you are able to look into these things, then you check the important factors that might affect wound healing. The primary important things are to make sure that the vascular system is intact. Similarly, make sure the infection and the injury components are sorted out. The next most important thing is the pressure, the VIP. The pressure imbalance is often due to a situation where there is a deformity on neuropathy. So it's important to see whether there is any deformity or neuropathy going on. And unless you identify it, the deformity and neuropathy is going to cause problems. So if there's deformity, either you correct it with surgery or you try and make sure you use good pair.
Dr. Tushan, we can't
Yeah,
hear
we
you.
can't hear. We can't hear.
Sansa, what happened? Did he drop off?
Yeah, I think he has a technical problem.
Yeah, I called him.
He's joined.
Okay, put him on.
Sorry, my apologies, I lost my internet, I think. I'm back.
Tushan, they want to go a little slower.
Slower, right.
Yeah. How's your work situation? Are you finished or?
Work is done, work is done.
Fine, okay.
Recovered my flu.
Okay, try to do, little slower, it seems.
So what we taught was initially, when you have the patient with a chronic wound, first of all, see and identify the primary causes. Essentially, if you can't remember all of these things, think of three things: the vascular, the infection or the injury, and the pressure. So these, I'm still not at wound preparation. I'm just trying to set the stage, which I thought I'll just go through this fast, but I'll take it slow. So just to get to you, we are not at the wound bed preparation yet. Before we even think of preparing the wound, what is advised and what we should be doing is to make sure that we solve the primary things out. At least the vascular, infection, and the pressure. Vascular, there are three things: arterial, venous, lymphatic. Those have to be looked at, assessed. If they are there, you got to sort them out. Infection, with there, sort it out. There's deformity and pressure, sort it out. Do the offloading, make sure those things happening. Otherwise, there's no point putting a dressing on a healed wound that you're going to keep on walking on. It will never ever heal. Now, once that is done, and you're done all of that, you need to think whether you are able to heal this wound. Is the wound healable? Is it worthwhile doing it? All that is important. Some wounds are not meant for healing. They're meant for sometimes palliation. Sometimes the wounds can be maintained. But they do think, put in this extra step where you look at the patient, talk to the patient, look at the various spheres, the society, the family patient is in, the capacity for them to use finances, whether they're able to come and see you. A lot of things are involved there before you can think of healing a wound and making sure it is healable. Patient must be having a decent family support, must be able to come and visit you, must have enough money to buy dressings or come to for transport to come and see the patient. The food itself must be salvageable. Patient must have enough reserves in physiology, nutrition, to withstand all of these things. So determine the ability to heal. Only once these are done, then we get to the wound care and the wound bed preparation. So only now I'm actually coming to the topic that I was meant to talk today about the wound bed preparation. But I want to tell the parts early on, so it's very important that you understood that we do the same thing, that the initial things have to happen. Otherwise, we might feel that it's only about dressings and nothing else. Right. So if you think of wound bed preparation, again, to make things very simple, we talk about a concept of time. Now, the whole idea of this is you think of time as an acronym. Some say dime, some say time. Same thing. TIME stands for four things. T for tissue, I for infection, inflammation, M for moisture, and E for the age. Now, wound bed preparation is about looking at these four things and sorting these four things out. That is what we're trying to do. So, what happens in each of these is what we need to understand. So, preparing the wound is about making sure the tissue is good, making sure the inflammation is under control, making sure the moisture is the adequate level and maintained. Make sure that the wound is epithelializing. This is essentially wound bed preparation. And again, to remind, do not start wound bed preparation until that initial things have been done, assessed, and sorted out. You may dress the wound, but don't spend time preparing unless there's an absolute requirement for it. For example, source control. But the essential things have to be sorted out. Right. Now, if we take these one by one, and we go a little slow on this, T is for tissue. It's about debridement. Tissue. What we want is, if you look at a wound bed, we talk about the different parts of the wound, the edge, the margin, the surface, and the base. But you see the surface of the wound, we get different types of tissue. To make it easy, think of colors. Often it is 3 or 4 different types of colors that normally exist in any wound. White is often scarves, that is not really a wound color. You can have red, yellow, black, and pink. Black tends to be necrotic tissue. Yellow, sloughy tissue. Not pus, slough. Little difference in there. Red is granulation tissue. And pink is a new skin that forms at the edges, which is epithelialized new nice skin. How? Put some graphical pictures. You can see the black part in the middle, that is necrotic tissue. You see some yellow stuff there in that wound, that is slough. You see some nice red color tissue, that is granulation tissue. You can see a pink surface of skin, that is epithelial wound. But if you look at all these 4 pictures again, you'll figure out that some of these pictures have all 4 colors. The one on the left, for example, has black, it has yellow, it has red and pink. The sloughy wound that I showed you as yellow has red, yellow, and pink. So all these different colors exist in a wound. What do we want? What we want is red and pink. Anything that is not red and pink, we do not want in the wound. So the whole idea is to remove the non-viable, unhealthy, different colored, necrotic, infected tissue, because all of these tissues that are not red or pink will actually impede the process of healing. Removing all this stuff that is not viable is what is called debridement or debridement. How do we do it? There are different methods available. We'll try and go through some of this one by one. But again, to remind, let me just show some more pictures. Necrotic tissue, the sloughy tissue. Here, of course, there is slough, but you'll also appreciate that there's a little bit of creamy color, yellow color, sticky stuff as well. And that could be a little bit of contribution from pus as well. I'm sure if there's opportunity arise, we can talk a little bit what is slough, what is pus. But there are 2 different things. Every wound will have some degree of exudate, and that will cause some degree of slough. Pus is a collection of infected tissue. And that is different because it is unhealthy and should not be kept because it's a focus for infection. Slough itself is not a bad thing all the time, but we do like to remove it if possible, so the healthy granulation tissue can come up and go forwards. Also, sometimes the presence of slough, it might not allow the skin to epithelialize, the wound to epithelialize. So again, we remove all of these things. What you love to have is this lovely red colored tissue. You can even put a skin graft on this. Right. So if there is unhealthy tissue, what you got to do is to start thinking of debridement. How many types of debridement methods are there? There are many, many ways of doing this. As a surgical person training and a vascular surgeon, surgery tends to be the most often used way of doing a debridement. You quickly come, take a scalpel, cut away all the bad tissue, everything that looks unhealthy, that looks non-viable, that doesn't look like thread or pig, you cut it out completely. That is something doable. Now, this may be a gold standard. It may be the fastest way of doing this, but the problem with this, it requires competency. Not everybody can do it properly. If you don't do it carefully, you might actually do more harm. No one can debride only the bad tissue. It's never ever going to happen. Anybody who debrides, even the best surgeon, will always either remove less or remove more. That's going to happen. So surgery, while is very important, it's not something you want to be doing at every single visit, because then you'll be doing more harm than any good. So surgery is often kept in the initial stage. A lot of tissue burden, a lot of bad things, a lot of pus, a lot of necrotic tissue. So to patient is also unwell. So then that is the best way of trying to get things done, removed faster. Often with diabetes, people have neuropathy. So anesthesia and things are also not required for most of your patients. So it can be done even in the outpatient setting. Right. Other options, let's think of mechanical debridement, not often used here. They tried to bring some to the market a few years back. I don't think it ever really got hold. But things like Versace use pressure, water pressure, ultrasonic devices, sonosage to try and see if they can break biofilms, break wound surface bugs, and entice angiogenesis, remove the surface tissue with fast pressure water. The mechanical stuff is not often available. Now, the thing is, every wound does not require sharp debridement. The whole way of dressing the wound is also, we can actually try and allow that slough to slowly become autolyzed, to become dissolved, to become soft. And when you put a gauze swab or a dressing on it, every time you take the dressing off, it pulls a little bit of the slough also. Sorry. So some wounds can actually be dressed, debrided with dressings alone. Will come later on as well. Now, missed a few slides here. Things like honey, things like biological debridement using maggots, things like using stuff like acetic acid or Milton solution. They all debriding solutions. They can autolyze and let the dressing do the debridement, and is actually cheaper. It is less harmful for the body. However, it takes some time. So when it is not very important to do this debridement super fast, dressings are actually not a bad way of doing it. We used to use PAPE in those days, enzymatic debridement. Enzymes like PAPE, now they are commercial products. These can actually do some debridement. The honey used for debridement. Maggots used for debridement. So there are dressings nowadays also that we can use to help the debriding process. Sorry. So the task of the wound bed preparation in the time concept was first to take the T, and that is to say, look at the tissue. Think of the healthy tissue you want. Anything that is not red or pink is not essentially healthy. You want to remove it. Figure out what is the best way of removing it. Is it surgery? Is it mechanical? Is it autolysis with high saline or acetic acid or miltons or just fluid? Or do you want to use maggots? Do you want to use honey? Do you want to use papain? Lots of options are there. Once you do the right, you also need to think about the concept of infection and inflammation. Now, I'm sure it's been talked a few times in all these sessions, but one of the biggest problems of chronic wounds is your antimicrobial burden, the amount of money people spend on antibiotics. It is not simply the cost of the antibiotics, it's also about irrational use of antibiotics, and that leads to resistance. So if you keep on chasing the bugs that are getting better and better and more immune to the bugs your antibiotics are giving, remember, any wound will be contaminated. There are bugs all over the place. So if you surface swab any of these wounds, we'll always have a culture sample positive. But that does not mean that that is the one that is going to cause problems. It is the high levels of uh, uh, bacteria that cause detrimental effects by stimulating the host response and attacking the host system. Those are the bugs we really want to try and sort out and find. And if you can remove that bioburden, that is the whole idea of sorting this I part of the time concept. Now, how do we do it? We can give systemic antibiotics, IV, or you can give topical antibiotics. There was a time when people used to give antibiotics to the wound. That doesn't happen often now because it's not very effective. Crushing tablets and putting the wounds, never expect that to work. But any form of antibiotics you use will cause resistance. We now know that there are topical antimicrobials that we can use. These are not antibiotics, they're antimicrobials. And they are useful because they cause very little resistance. They are able to tackle different kinds of bugs of a bigger spectrum. They can have some hypersensitivity, but you are also able to use this with different other properties. And we'll talk a little bit later on. So, how then do you know that there's infection? We talked earlier on, all these wounds go through an inflammatory phase. Is it actually inflammation you're seeing? Or is it infection you're seeing? How do you know this? And there are different ways of looking at it. Especially with diabetes, you'll remember and find out that it's not always easy. You don't often find the classic symptoms and signs of infection because of their immune modulation. The patient might be so bad with sepsis, but no fever, counts are pretty much normal, CRP may be little high, there is no warmth, no real pain, some swelling, not too bad, but they might be having poor appetite, not looking well. So it's not easy sometimes, and often people can miss it. No harm of theirs. There are two criteria that they talk about. One's called the NERDS criteria, one's called the STONES criteria. NERDS is looking for local wound infection, and STONE is for looking for deep and surrounding infection. So while I don't want to put too much into technical things, if you are able to just go through this and see, then it's useful to try and figure out what they talk about. These are not very complex. These are things that you all know about. If you look at the wound, what will make you think that the wound is infection? So things like it could be just a very straightforward. Sorry, the wound you're dressing. It is not healing. No, non-healing wounds. You expect a wound to at least come by about 20-30% after about 4 to 6 weeks of wound care. If it is not healing, think of infection. If there's a lot of exudate, lot of discharge, patient sometimes says, "මේ පරණ මහත ඩ්‍රෙසින් එක තියාගන්න හම්බුන්නේ නැහැ. ටක් ගාලා තෙමුණා. මේ හරියන්නේ පොඩි ප්‍රශ්නයක්. මේ පාර තියාගන්න හම්බුනේ ඉස්මකතිය වැඩි." Increased exudate is also a feature, some type of infection. The awkward smell you get, lot of debris, excessive bleeding, contact bleeding, friable granulation tissue, These are sometimes signs of an infective process going on. Can be acute, can be chronic. At the same time, what are systemic features? So nurse talks about these local features. Think of the other things that you might know in systemic features. Patient be systemically unwell. And then again, you might find that the patients have the high febrile fever, probe to bone of osteomatic bones. They keep breaking down. There's a lot of erythema, a lot of edema. And then, there is not simply just a local infection, you find systemic effects. And if there's only local infection, you can think of topical therapy. If there's systemic infection, you'll have to think of systemic therapy. So alone, a topical antimicrobial dressing alone might not work when you got deep and surrounding infection. Remember, infection can be superficial infection like a cellulitis. It could be a deep infection like a fasciitis or a myositis, even things like necrotizing fasciitis. It could be involving the more deeper structures, like, for example, bone, as osteomyelitis. It could involve joints, as arthritis, so septic arthritis. So all these things can be there. So it's important to try and figure out what are the components involved. So if it is infection to such a point where you can't control with all of these things, then sometimes you combine the T and the I. You saw the tissue out, you debride, sometimes often surgically. It not only removes the unhealthy devitalized tissue, it also removes that bad infective focus. So you can actually use debridement to reduce the necrotic burden, tissue burden, as well as the bioburden. So by this time, having done that initial prep and we come to wound bed preparation, we have made sure the most appropriate form of debridement has been sorted out. We've also made sure infection inflammation is kept under control. And we can sort it out. So when you talk about sorting antimicrobial dressings out, two particular components are often talked about because they have very little resistance. What dressings might we be using in order to, I think there's a separate lecture on dressings. I don't want to talk too much about dressings, but we do use certain elements of these when you're doing wound bed preparation. For example, hydrogen peroxide also can be used as to control infection. Concentrated betadine can be used to control infection. Acetic acid, Milton solution, hypertonic solution, all these can be used to fight infections. You got to also make sure that some of these products, like for example peroxide or betadine, it's not able to differentiate the good tissues and the bugs. So when it acts on every single tissue that is touching upon. So you might control the infection, but you might also damage a whole series of good tissue as well. So we therefore use selective products that only attack or fight the bugs. And of these, the commonest antimicrobial things we use are silver, iodine. Now we find a little bit of copper also happening. These heavy metals have a place of fighting antimicrobial activity. They destroy uh, uh, a different array of bacteria and bugs, not necessarily specific to particular strain. So they're actually able to fight a larger spectrum of bugs. So think of silver, think of iodine, think of copper sometimes as useful methods of fighting infection and using dressings with these. So when they, at some point when there's a lecture or discussion on wound dressings, you can ask about these things as well. How to make sure the right dressings are used. Sorry. Right. So if these have been done, the T has been sorted out, the I has been sorted out, then we go to the moisture or the M. Now, we talk about dressings nowadays, modern dressing as moist wound healing. We need to have the optimum moisture level of the wound for the wound to heal. It is like planting paddy. If the moisture is not good and it's too dry, your paddy won't grow. If there's too much of moisture and the water hasn't been controlled, then everything gets soaked and damaged. Same as for the wounds. A moist balance is required to make sure things are kept in place. Just like us, we will not do well when we're dehydrated, nor will we do well when we have too much of water. Get the right balance. Now, how do we maintain the optimum moisture in a wound bed? It is important to do this because if it's too dry, then it scabs. Then you can't epithelialize. And then the cells can't migrate. The wounds won't be able to work properly. The enzymes won't work properly. Too much of edema, antibiotics won't work properly. All the growth factors get diluted. Enzymes get diluted. They can't stimulate others to come through. When there's a lot of moisture causes maceration, the skin gets damaged. So we need to find out exactly what the moisture levels are as we're preparing the bone and try and figure out how do we get it back to the optimum middle moisture level. So then there are dressings for do this. You can be at the end of the spectrum of very dry wound or to a very highly exuded wound. For example, all the ischemic wounds like a dry gangrene would be dry, parched wound. If the on the other end, something like a varicose vein ulcer or a infected diabetic foot ulcer with pseudomonas will be highly exudating, lot of water, lot of moisture. And you can then therefore decide on dressings, and you can ask this at the dressing lecture. You choose a dressing that will help you to maintain the moisture. Your wound bed preparation, moisture revolves around making sure the wound is not too dry, not too wet. If the wound is very dry, you will want to use a dressing that gives some fluid to the wound. Even a transparent film will capture and catch the sweat and the natural moisture that is leaving the skin and retain it and catch it. And that will also make the wound slightly moist. As you go from dry to exudative, you find there are dressings that can absorb excess moisture. They could be alginates, foam, hydrofibers, hydrocolloids. They have ability to absorb different capacities of moisture. Alginates and hydrofibers are very good to absorb excessive moisture. So all these particular types of dressings we can use to make sure sorry, that the appropriate moisture is maintained. Also remember that every single time you look at a wound, this has to be done. Because no wound will have the same moisture level at every single visit. When you see it next time, it will be a different moisture level. So then you got to try and make sure you change the dressings. Change the dressing that will give the most optimum moisture at that time. Also, you can ask a little bit more and talk about dressings with this. When you're preparing the wound, sometimes you can't put one dressing to try and solve the debridement out, one method to solve the infection out, one for the moisture level. You can't do that. You can't put 3 or 4 different types of things and put to a dressing and make a wound. So also remember, certain products are able to combine these. You can have a dressing, for example, that has a moisture absorbing foam dressing that also may be having some silver in it that will help to fight and destroy the bugs. You might have a hydrogel that can give fluid to the wound, maintain the moisture for dry wound, but at the same time, it has a little bit of iodine, for example, to try and control infection. So these can be combined sometimes. So when you're selecting dressings, you need to make an assessment that every single visit to try and see where the problems are, what is going on, what is the current wound bed situation, what is my tissue situation, what is my infection situation, what is my moisture balance, and you choose the appropriate dressing that matches all of these things. Finally, if you have got all these things done, you got the right tissue debridement plan, sort out the infection, sort of moisture out, you have a lovely red color tissue granulating, but you don't get to pink. You can't get pink to come in for various reasons. The epithelium is very poor. There are different junk therapies that are available now. They're very expensive. And these are more like growth factors and regenerative factors to try and help the wound to regenerate and to heal. Not often stuff we use. So I'm coming back to this old slide again at the latter part of my presentation. Remember, wound bed preparation starts much before you even think of touching the wound. Really important to understand there's a person with this wound. This person may be having primary causes that will prevent the wound from healing. These have to be identified. Once you identify these, then you can think of sorting it out. Send the patient to the most appropriate relevant person of that specialty that can sort it out. If it's revascularization, ischemic, you have to revascularize. Venous, you got to sort the varicose veins out. Sorry. Lymphedema, you got to start compression properly. Neuropathy, got to get offloading. There's solid sepsis, you got to get source control. Until you sort that out, there's no point in doing anything else. If you're done that, determine the ability for the wound to heal. Not every wound has to go on the same pathway of healing. There are different pathways. You need to choose based on the discussions you have with the patient, with the family, the societal factors, financial factors, or the patient's, what the patient wants, first of all, to see what is the pathway you're going to take. If you think you're going to go on a pathway that requires you to heal this wound, then you come to wound bed preparation. Again, it's very simple to remember. Think of 4 things. Time for tissue, I for infection, M for moisture, E for age. You got to get the right tissue that you want that requires debriding unhealthy tissue. Get the inflammation, infection under control. Make sure you use dressings that give the absolutely important moisture balance. And then make sure that you can epithelialize. With all of this, remember at the beginning, it's all about the patient, the family. Make sure they all understand what's going on. So I'm summarizing things all over again. Wound preparation is about all of these things together. Unless you get all these things in, you cannot have a holistic wound care that's going to work. Thanks. Sorry, I'm just recovering from a flu. My voice is very bad. Been coughing 2 times, but I hope that made some sense. Feel free to ask any questions. I'm free. I'm okay. Can talk and ask any question. But I hope there was some understanding about wound preparation. And I think if the program is like before, there will be a separate lecture on wound dressings, and we can clarify how we use those particular types of dressings for wound bed preparation. But the principle is to get the initial thing sorted out. Sorry.
Thank you very much, Tushan. It's very concentrated but very well articulated. And the presentation is fantastic. So thank you very much. Any questions? I'm sure there are questions. one ask, so we can we use SSD similar to betadine dressings widely? Usually we use it for burns. Now, basically, this question you should point at the direction of the dressings lecture. But anyway, yeah. Would you care to explain, Sushan?
Question either can be used.
Can we use SSD similar to betadine? Can we use?
Not sure what the context was for birds.
Can use SSD similar to betadine dressings widely for burns?
Well, mm, I don't know how to answer that question honestly. But SSD has been used for burns. It has a little barrier effect on it. Still has some antimicrobial effect on it. The the barrier effect prevents maceration. Betadine is a different way of acting more bactericidal than anything else. But none of these are things we often use for chronic wounds. While it might use for acute wounds, thank you. For chronic wounds, the whole problem with all of these things, they are non-specifically damaging the tissue. So especially when a wound is healing, slowly, gradually, taking eons to heal, small increments of improvement for a day, for a week, you don't want to be using such products on a chronic wound because it will inherently damage the granulation tissue as well. So if in terms of a chronic wound bed preparation, we won't use it. For a burn wound also, you probably won't find plastic surgeons endorsing using betadines for burn wounds for a longer period also for the same reason. You don't want the toxicity of a betadine to cause damage. Iodine is different to betadine. So providone iodine is not the same as the iodine, they're two different things. SSD is used for burns, it's cheaper and it's also not bad the initial part, but it is again not meant to be a dressing that is used long term for burns. I don't think plastic would encourage that also. If I'm not sure that I answered the question that you wanted, but I think that's what I would like to say at least.
Yeah, I also think so. Yeah. Any more to be asked? The post, the one who posed the question, are you clear?
Yes, I'm clear. Yeah.
Okay, good.
Sorry,
So the next one is what wound dressing products contain copper? Yeah, I think that's quite clear. So I mean, we can't promote brand names here. And there's a separate lecture for dressings. Anything to add to that?
No, I think because I think we had a lot of overlap last time with this. I had some reason I as a prerequisite, I made sure I don't do a lot of talk about dressings, but just add a little bit that's relevant to the wound bed preparation. I think History or whoever's doing the dressings will be able to answer all those questions about the dressings. But if there's any on the wound bed preparation, I'm happy to.
Yeah. So rotational dressings will reduce tissue damage while controlling. So we will answer all these questions during the wound dressings lecture. So all about dressings.
As is far not always bad. At what level should we decide?
Yeah.
So that of course is fair enough to ask on this this particular topic. So it's like this. The problem with slough is it will impede wound healing to some point for different ways. It's foreign tissue. It could cause a medium for bugs to grow. When there is slough, it doesn't allow the wound to granulate properly from underneath. When there's slough, it doesn't allow the epithelium to happen because the epithelium, the keratinocytes can't migrate in when there's slough disturbing and obstructing the pathway. When there's slough, whatever dressings you put, all your expensive silvers and stuff, they actually don't go to the wound bed. They stay on the wound surface and the slough absorbs it. So it's difficult to say and quantify at what slough content you remove it. Slough also has a varied spectrum from being very uh, exudative and very watery to very thick and hard. The very watery, thin slough is not a bad thing. It often gets removed with the dressings, we do the dressings with autolysis. A harder slough that is more scary and more organized will actually impede more. So when it appears that the amount of slough is impeding the wound healing, that is when I would decide to remove the slough. Is I think what I can say. To can add to it.
Yeah. So, yeah, basically that.
One more question, sir.
Yeah.
Is there any particular types of wound where we can use acetic acid or Milton solution for dressing?
I mean, acidic and milk are the commonest things we use in our world. They're very cheap. They're not expensive at all. We use 1%, 0.5 acidic acid. Use 1%, 0.5 miltons for the dressings. The thing is this. Acidic acid might be a little better for pseudomonas, etc., etc. But whatever you use, acidic acid is basically vinegar. After about 1 hour, it becomes water. Say for Milton's. Milton solution, you put sodium, whatever, after a little while, it is water. So the effect of that particular agent you're using is not going to last for too long. So it is same as using saline after some time. So then you got to see, is that actually what you want? You can't leave acetic acid for a week, for example. It doesn't make any sense because you're not achieving any effect of the acetic acid. Then it's almost using saline. For some wounds, that might be okay. For some wounds, not okay. Whereas these newer products that are able to release bactericidal agents for a week, slowly, incrementally, those are better because you can actually keep it for a week. So you got to decide what you want to do with your wound and your patient. Are you going to dress it daily? How often do you want to dress it? Are you trying to sort out the infection? Or do you just want moisture with some saline? If the answer is you are dressing it daily and you then no point spending money on expensive dressing. If your answer is I just want the saline to be there as an autolysis, I'm not too bothered because infection, it is not so badly infected. It is actually not so badly macerated. Exudative also. It's little exudative. The wound is mainly dry rather than exudative. Then, of course, in acidic acid might be okay for a week. So you need to decide on the wound how you sort that out. And for some wounds, acetic acid might be fine. Particularly, acetic acid is used when there is worried about pseudomonas. It's I think something that you often talk about.
Yeah, it's true. It's for
And
pseudomonas.
sir also mentioned about the honey dressing, sir. Are we currently is that in the practice, sir? Honey.
There are commercial. There are at least two I know of commercially produced honey dressings. There are honey sheets and there are honey gel dressings. Both are there in Sri Lanka these days. You can't technically use the honey in the supermarket. That doesn't work like that. Particular type of honey called the Manuka honey is what is considered that has the ability to have a biocidal effect on in use in wound care. But it is quite effective if you want to try it and see. Also, it does not cause hyperglycemia like some people think.
Right. Thank you, sir.
True. Any other questions? There's one in our pre-test. There was a question: time. What is meant by time? What is meant? Was the meaning for hours regeneration? It's about the tissue the promoting the tissue regeneration. About growth factors and all those things. So time is getting sort of extended uh, uh, in the current scenario. So with more research coming in, more consensus coming in, is there anything to add, Tushan, on that?
Yeah, like you're right. So I think it's easy to think of time, the things that people have found new, timers. Timers is also there. They
Yeah.
have the S at the end for society and social, all those things. So there is some new changes, but essentially, I think in terms of wound bed preparation, time or dime still remains the important things that we think of at each and every single dressing. Every single time you see the wound, what's the tissue, infection, moisture, the epithelializing. So that in your mind will help a lot. But yes, timer is there. Now timers is also there, but I don't want to tell too much about those things also.
Yeah, timers is the new thing, I think. So, can you please explain edge effect gains? It's there in the YouTube though. So, yeah, I mean, I don't know. It's there in the YouTube. You will get the link, so you can listen to it repeatedly. I don't know whether to bother Tushan right now at 11:26, and he's suffering from flu. I don't feel like doing so though. Uh, I think better to listen to that in the YouTube. So,
So one more question, sir. How would you advise to remove stuff over the tendons or bones while wound bed preparation?
Are you talking about removing slough over the tendons or talking about the tendons itself?
Yes, sir. It means,
Yeah.
are we going to remove slough over the tendons if there are, or over the bones covering slough?
Yeah, so I think still there are two different things. Slough is in general something that you find on the wound surface. If we talk about how you describe a wound, you at the surface and the base. In terms of contents of that wound bed, you might have granulation tissue, you might have bone, you might have sometimes exposed joints, you might also have tendons and stuff as well. In general, the problem with tendons is that these are gliding tissue. There's tendons are gliding back and forth. Each time there's movement, it doesn't allow granulation to come on top of the tendon. The tendon remains. And the problem with diabetes more than anything else is this risk of infection. And when there's infection at exposed tendons, often we get played out. The infection tracks around the tendons and you find suddenly sepsis popping up in different places here and there. So if you think that the tendon is expendable, කෙනෙක් අයින් කරන කමක් නැහැ වගේ, where you don't destroy the entire architecture of the foot and you lose salvageability, I often try and remove it. Might be partial remove, might be full removal. I remove it because I'm worried that there's infection and I don't want to take a risk. If you're careful, you can leave tendons and make sure you watch and make sure it and that's it sorts itself out. But it's the internal risk you take. It is not really the slough on the tendon. Slough you can do that is fine. But if you have exposed tendon and you have breached the peritendinous sheath, then the tendon starts to desiccate. And then what happens is it's eternally a focus of infection and becomes a mess. And then you can't heal the wound easily. Rarely, of course, some of them damage and you might close it off. But if it is possible to remove it without causing too much of damage, I often remove it purely because it's less of a risk for me to worry about. I hope that was helpful.
Yeah, I think that does justice to that question. Are you happy? The questioner, are you okay?
Yes, sir.
Yeah.
Oh,
Okay.
yes.
Fine. So the next question is about slough in a wound with no vascular compromise. This can be discussed actually in the dressing lecture as well. But what do you think, Tushan? Slough, management of slough. in a non-vascular compromised wound? There
No,
are so
but
many ways
your
to do it.
white stuff, what to use a bit? I couldn't quite understand the question.
Yeah.
But the question is to
Flat wound by white slough. What to use for wound bed preparation? Vascularity for us and vascularity, okay. So I think the main question is how to get rid of the slough. So I think it's a quite well explained during the lecture. There are so many ways to, I mean, you can use sharp debridement. Otherwise, there are so many other things that you can use to debride. Papain, honey. There are so many things. So I think we have already answered that question. What do you think, Tushan? Is there anything to add?
I think so. I mean, there's a separate context. Vascularity is okay, then you can use any of those things, no problem.
Yeah. Best is sharp debridement, isn't it? If I'm not mistaken.
Depends on
Experienced hand.
how fast you want to remove. Sharp will have some harm, but if it's important to do it fast, that is okay. Otherwise, things alone can do it. Can use autolysis if you want. So all those options are there. Mechanical is there if you have the facilities. All those options are there if you want.
The original the question of this, are you satisfied or do you want to ask more? Rukshan.
Yes, sir, answer. I got the answer, but problem is the wound is chronic wound is large. So therefore, patient according to patient is for 3 years, and patient is going different places. But problem is wound is getting to heal and reoccurring again. There's a problem with the wound bed. There's not much of inflammation. Patient got severe pain, and there's a thick white slough. I have used several and stuffing agent because very difficult to do surgical debridement because the wound is flat, and if I try to do surgical debridement I will do more harm. Therefore I have tried with the chemical ways, but wound is healing and recurring again. That's why I asked the question.
Yeah, just go back to the drawing board. In the first lecture of my lecture, I told you if there is a problem, I mean, it's not, if anything is not working, go back to the drawing board and reassess. Just check whether it's an atypical wound. Are you sure you are treating what kind of a wound this is? Just think about the diagnosis, wound diagnosis. So, and I think your question should wait till the end of the course. Once you have gone through all of it, you might not even ask this question. But anyway, just think of atypical wounds, something of dermatological this thing. Say like pyoderma gangrenosum, that sort of wound, or dermatitis, that eczema. Have you thought of those things, or a vasculitis?
I think it's a vasculitis type wound. I have did several referrals, but still no diagnosis. Vascular referral also done. I think it's mostly look like vasculitic type wound.
Yeah. Have you done a dermatology referral?
Ask patient to go. I'm still trying to send the patient to the dermatologist, but patient is not
The
going.
idea is no, that in this kind of scenarios, you need help. If you can't sort of do the math and solve the scenario yourself, you need senior help. So this is where you have to, one of the red flags I mentioned in my lecture, to refer. So I mean, it's not not one person can do wound care. We should have support from all the other seniors, juniors, all those people. So this is one of these scenarios. So have we answered your question at least 50%?
Yes. More than 80% answer is given.
Yeah. Okay, thank you. So anything to add, Tushan?
No, I'm okay with that. Okay. That's
So about Komarika, we can actually, a bit about PepSob. All those can be discussed during the dressings lecture. But anyway, Tushan, you want anything to say about Komarika?
I think all of these things might have some benefit. It's just that a lot of studies have not been done, and the scientific um, studies don't often have the same uniformity. There are good things in Ayurvedic medicine, but if it's not standardized, then become difficult to use across the border. Turmeric has its good effects, but for the moment, it's really difficult to endorse something without having a commercial nature to it and making sure that the product is standardized. Is the biggest problem with some of these native treatments. Essentially, I wouldn't use it, but I know a few people who use these things. So probably I leave it at that. But otherwise, I might be offending some people who are proponents of Komari also. It's not fair, but
Yeah, PepSob is a trade name. So let's forget about PepSob. If you're asking of papain, it works. The preparation, it works, whether it's in a gel or an ointment, that's debatable. There's something else that we'll be teaching those things in during the hands-on sessions. So since you have asked PepSob, I think it's not fair to answer that question though, because it's a trade name. We are not promoting anybody here. We are not funded. So papain works. Anything to add, Tushan, on this papain?
I think there was a time when we didn't have any commercial products. So there was a time when we had to find the pepper and scrape the peel and crush the peel and so for whatever worth it is effective. I think it's more effective than the commercial products that are there nowadays that are not. I don't think they're the same effect. But end of the day, it's about you deciding what you want from your wound and from the dressings you want. That is the main thing you want to ask yourselves. Why am I putting a dressing and what I am trying to achieve with this dressing? If you know what you are trying to achieve, then you can choose the right dressings, and all these dressings keep on changing over time. There are so many in the market, but you should be able to figure out what is the scientific basis for doing all of these things and have some science and some principles on what to base your decisions on. Otherwise, කදසක් එකක් දාන දාලා පහකක් දානවා ඊට පස්සේ මේක දාලා බලන පස්සේ දාන්නත් not good, nor should you අරගෙන ටිකයි මේකෙත් එකතු කරලා එහෙමත් you should not be doing also. So have some general principles on what you work and how you work, and have some science and some understanding as to what you would want these dressings to do. And at each visit, you ask yourself, what am I trying to do today for this particular wound? What you do last week will be different this week. And then you can choose whatever dressings you want and use it anywhere you want. So that's sort of what I would say.
Yeah. So I mean that's the point of this whole learning exercise, for you to have a scientific basis for what you do and your approach to wounds. So there's another question about cold plasma. Cold plasma therapy for wound bed bacteria kill. So not quite sure what it does. Is bacteria killing bacteria only? Anything, Tushan? Anything you want to say about cold plasma? So this is very new therapy.
Sorry, I unmuted myself. Not very familiar, I must say. I don't know all the evidence for it. You're talking about cold plasma, talk about
killing the bacteria. I'm not sure whether I have read this, whether the only thing it does is for bacteria killing. I can't actually remember. I will post.
this whole concept, I think, is about trying to ultrasound, HIFU, and then plasma waves and nano waves, gamma waves. They have been tried many times in wound care. I don't know if there is enough evidence to support or justify, but it is trying to destroy the biofilms, trying to destroy the bugs, trying to disrupt the membranes and the barriers, and for better penetration. Sometime back, some guys were coming and they're using ultrasound shock therapy. They all work on the same principles of trying to sterilize, trying to disrupt biofilm, trying to stimulate angiogenesis. Again, I don't know whether there are no randomized trials, but I don't know how much of it is market driven and market sponsored to say if it's really working or not. Certain things like silver, iodine, copper, heavy metals, it's known. Those are established. This I don't know to say 100% whether it's properly established. I don't think it's in the guidelines yet. Don't know. I don't think so.
Yeah, exactly. I also couldn't find much, convincing evidence on this plasma, but it's sort of a adjunctive therapy like hyperbaric oxygen. So we'll leave it at that. If I could come up with a better answer, I will post it tomorrow in the thread. So the next one is, could you please explain about how to get wound biopsy? I think we will try to incorporate that into our hands-on session. I don't think that is in the purview of tonight's lecture. I don't think it can be taught. What do you think, Tushan? We can, of course, we can incorporate that into the hands-on session.
Yeah, I think you get a wound and maybe try and describe from the wound how to maybe a better way of doing it.
So, how to manage with bone involvement? Next question.
Sorry?
How to manage with bone involvement?
Bone infection. Okay.
Yeah.
So I essentially talk about probably diabetic foot disease and not other types of disease. With diabetic foot disease, talk about deep tissue infection. One part is bone infection. Principles are always the same. If you can debride, you could debride. Certainly, some bones are okay to remove, like a sesamoid bone, for example. It's okay to remove. Part of the hallux can be, but if it's a major bone that is going to disrupt your foot architecture, then you can't remove it. If you can remove the bone and remove the focus of infection, then you are back to soft tissue infection only, which you manage with antibiotics. Problem with bone infection, tissue penetration of or bone penetration of antibiotics is not great. Also, it's difficult to get samples of what the bug is. Your wound biopsy, your swab won't tell you what the bone sample bug is. So, therefore, you might mistreat it. So, principles are, if you can remove it, you can remove it. That is fine. If it's a well vascularized foot, you could even leave the bone behind and treat with antibiotics. If you're treated with antibiotics, not like a soft tissue, you got to give for extended time periods. You're looking at a minimum of 6 weeks of antibiotics, and sometimes even up to 3 months of antibiotics because it's osteomyelitis. So that's probably what I would say for management of bone infection.
Yeah, agreed. So that is 133. Are you satisfied with the answer, or do you want to ask more?
One small thing. So if you're going to go with the debridement, so for example, if it's the toe, and we are going to remove part of it, do we have to, so like where will we like stop? Will it be the next joint, or can we go a little bit further?
It's like this. So two different things. Then you need to know diagnosing of osteomyelitis, which part of the bone is involved. Not very easy. Sometimes X-ray or MRI will show the obvious part. It might be a little bit more than that. Often when you're doing the debridement, somebody who's done it a few times will be able to sort of figure out what is the bone that is healthy, what is not healthy. So in terms of how much you remove, it depends on, you don't want to do like a malignancy clearing debridement where you want every single macroscopic, microscopic part removed also. That is not essential. What you're doing is removing the major focus so that the antibiotics can work on the what is left behind. So it's always, so science of debridement is to debride, but without disrupting the architecture and compromising future salvageability. So if you don't want to be removing the entire metatarsal head and the metatarsal bone and the phalanx and then leaving soft tissue behind on a useless, you might remove the toe. Nor do you want to keep on debriding and removing the next joint, the next joint, the next joint also. So idea would be to try and get a little rough idea as to how much is infected using whatever imaging you have. Second, I would do is I would debride up to the point where I think is essential to debride, knowing that I might leave a few things behind, which I can sort out with antibiotics and other forms of treatment.
Yeah, other thing to think about is how to wear weight bear. There should be a triangle of weight bearing at the end of the debridement. So, so are there any other questions? If there, I mean, it's very late now, and we are supposed to finish at 11. So, given all the technical difficulties and time delays, I think we are supposed to finish at 11:15. Now, you can imagine the commitment of the lecturers staying this late. So, especially Tushan with his flu and he's down with flu. So, are there any questions? If there are no questions, we can call it a day. And Madam Renuka, can we call it a day, Madam? So we should call it a day. So Tushan, thank you very much, and it's always a pleasure to listen to you. And it's a very concentrated lecture, very well articulated, and very well presented. Cannot do better.
Yeah, thank you. It was a very nice lecture. Even I was listening. It was. Thank you very much, Dr. Tushan, for your great commitment.
Thanks for inviting, Madam. Thanks for inviting.
It's always pleasure to invite you. It's that good that you accepted our invitation.
No problem, Madam. No problem.
So we'll call it a day. There are any questions you can post in the thread. We will answer. So, Madam, shall we officially?
Yeah, definitely. Now it's too late for everybody, no? Yeah.
Of course.
Thank you.